Good afternoon, everyone. I'm Richard Barron, the Executive Vice Chancellor for Health Affairs at MU and the Executive Director of NextGen. Welcome to the third session of our NextGen Precision Health Discovery Series. These discussions are intended to keep you updated on NextGen progress, as well as highlight precision health developments and cross-cutting topics that are essential to our success. Our speaker today is Dr. Ann Sayles. Dr. Sayles is a professor in the Department of Learning Health Sciences at the University of Michigan Medical School in Ann Arbor. As a research scientist at the Center for Clinical Management Research at the VA Ann Arbor Healthcare System, her work involves theory-based design of implementation interventions, including understanding how feedback reports can affect providers' behavior to impact patient outcomes. She also leads a partnered evaluation initiative funded by the VA Office of Nursing Services. I was introduced to Ann by our mutual colleague, Dr. John Spertus, who is the NextGen Faculty Research Lead for Precision Healthcare Delivery. John has had an ongoing program called the Kansas City Quality and Value Innovation Consortium, and he brought Dr. Sayles to Kansas City to educate us on implementation science. When I moved to MU, one of my goals was to get Dr. Sayles to this campus to educate us as well. Today, she's here to discuss areas of overlap between precision health and implementation, focusing on an emerging approach known as precision implementation. She'll also address how this approach might impact the delivery of health services, as well as challenges in achieving optimal outcomes. By learning the approaches of other health systems, we can bring these two complementary but different fields together. And with that, I'll turn it over to Dr. Ann Sayles.
Great. Thank you so much, Dr. Barron. And it is really a pleasure to be here. It's my first time in Columbia, actually. And the weather is great and the people have been wonderful. So I am looking forward to this opportunity to talk and also to have some discussion. I've kept my slides deliberately fairly brief. Most academics have a hard time keeping ourselves under control, but I'm going to keep it short and hopefully be able to really focus in on the discussion afterwards and hearing your thoughts and ideas. And let me just say that this is actually, I do a lot of talks where I've done the talk that I'm giving many times before. I've never done this talk before, so this is new and different. I've not talked about precision health and implementation science in the same discussion. And so I really am looking forward to the opportunity to hear people's thoughts and comments. So what I'm planning to do today is start with just sort of kind of definitional questions. What is implementation science? A lot of people ask that, and it's a very good question. And then as a layperson in this area, I'm going to talk about what I see as precision health at this point. Excuse me. I'll also focus then on some areas where I think there are some clearer areas of commonality, and then some areas where I think there are very definite differences, and then give a few examples. I'll try to weave examples throughout so that these things make sense. They're not just abstract concepts. And then I'm going to close with just some thoughts about how these two different but overlapping fields can work together and produce some interesting areas of collaboration. So I'm going to start with what implementation science is, and I'll just say that the dominant definition of implementation science is one that I've actually found is a little hard to understand. It's wordy. It goes on for a while. So I've actually sort of come up with a much shorter, but still in the same spirit definition that I use, because it makes it more sense to me, and I think makes more sense to other people. So really starting off, this is a science that studies a particular phenomenon, and that phenomenon is implementation. And particularly studies it in the context of healthcare, although I will just say that implementation science as a broad field is applied to many, many other sectors in society. I think health has been one of the sectors in which it is highly developed, but it is used in education, it's used in social services more generally, and it's used in manufacturing and other areas. So the idea is to study implementation and what it is, how it's done, what are the general principles behind it, of certain kinds of things. So that gets us into more definitional pieces. So if implementation is this broad concept of that these are processes of planned human behavior change under organizational constraints, which is the definition that I use, um, that gives us kind of the scope for what are we studying. And as I say, it's agnostic as to setting, sector, what it is you're studying. In my case, I study healthcare. And so what I'm going to be talking about will use healthcare examples. But as I'll mention towards the end of the slides, in fact, the origins of implementation science really were not in healthcare, but in agriculture. I also want to just say that implementation science is only one facet. There is the act of implementation itself. And then there is what I'm calling and is increasingly being called implementation practice. And in implementation practice, which overlaps a great deal with quality improvement in healthcare, the idea is to take some of the tools that have been developed through the science, the study of implementation, and use them to improve quality of care in the health setting or improve quality of education in educational settings. So now I'm going to venture into the area I don't know so well, and that's the question, what is precision health? And I will just say, I'm at the University of Michigan, we have a precision health initiative there. I've followed the literature to some extent on emerging ways of doing precision health in other places, what NIH calls precision health. It's pretty clear to me that it's a very broad-based field that's very synergistic and offers a lot of opportunity to a lot of people. I actually pulled this directly from the NextGen site on here at the University of Missouri, where what the statement is that precision health will develop interventions for individuals and populations to improve health outcomes. And by basing medical approaches on individualized factors such as genetics, environment, and lifestyle, rather than using a one-size-fits-all approach, precision health can improve diagnosis, treatment, and patient care more than ever before. That notion of improvement clearly overlaps between these two areas of inquiry. And I've highlighted some of the phrases here just to highlight some of the things I'm going to talk about in terms of commonalities and differences between what we do in implementation science and what people are doing in precision health and in specific places in precision health. And in particular, this notion of the individual and or populations, as opposed to the idea that there is sort of an average thing that works for the average person, which I think is something that we've used in healthcare for a long time. A lot of when we talk about effects of drugs, effects of procedures, effects of devices, we're often talking about average effects over sometimes very homogeneous populations, sometimes over very heterogeneous populations. And often that's where the difficulty in actually applying that to the care of an individual or to people in a particular population comes in. So I'll start with the areas of commonality. One of them is there really is no specific agreed definition across these two fields. People are, certainly I can speak for implementation science and implementation. People read into implementation science much of what they want to see in there. And so it covers things all the way from how do you write guidelines and what is evidence to how do you apply it to populations. My particular focus is in application in clinical practice, in populations of patients, and then care of individual patients. My actual focus for the most part is on providers and how providers behave, but the interest there, of course, is on how that then affects outcomes for patients. In precision health, my sense is that it's even broader in terms of people's interest and what they want to read into the idea of precision health. I think the common thing that I see across definitions of precision health that I've seen is that this is more individually focused, that it is more targeted, that the idea is to step away from this sense that there is an average out there, that there's some kind of median or central norm to which all people gravitate. There may be something that many people gravitate to and that can affect and influence and adequately treat a large group of people. But what we found consistently over time is that nothing treats everybody with a particular disease or particular health problem. Instead, there has to be some individualization, and precision health is a way of channeling and harnessing that. Another area of commonality is that these are team sciences. Nobody does implementation science alone, and nobody does precision health alone, because it requires interdisciplinary work and the lenses and the knowledge bases that people bring from different disciplines, and all of that has to come together and work together. And then both of them really use processes to develop and design new things. In implementation science, while we have a growing body of knowledge about kinds of strategies, about the barriers and facilitators or determinants of successive implementation, we also have to design new things all the time. Because, for example, as I'll talk about it in a little bit later, the work I do in long-term care requires one set of tools that address the specific problems and setting context of long-term care that's very different from the other space I'm working in at this point, which is in critical care. And one of the big differences is in how data flow in those two settings. In long-term care, if you check vital signs once a week or every 3 or 4 days, that's fine. In critical care, you're checking on a minute by minute basis. And just the velocity makes a huge difference in terms of how people react and behave, and therefore how implementation is going to go, what matters in terms of understanding the ways that people's behavior need to change and how rapidly it needs to change. And so there's a big focus on tailoring, which I will talk about more in a few minutes. Both of these are evolving and emerging disciplines. Neither of them rests on a very solid structure of 100 years of development. Instead, they're building as they go. The common metaphor that my colleagues and I use is, we're trying to fly an airplane, we're building the airplane, and we're not always sure how far off the ground we are. So figuring that out and figuring out how to get these things moving and produce results while also building it and putting in the scaffolding to make it possible to build is essential. And then finally, I think both of these focus on changing current health practices. And I think that's an area of commonality that's particularly important. And I think probably the area where there's the best overlap, particularly for research, but also for practice, because part of this is knowing what our current practice is, what are the outcomes that we're achieving, what are the processes we're currently using, how do these need to change, and what are the new innovations that will make those changes as effective as possible. And I should add here that I think piece that I found really interesting here at the University of Missouri in the Next Gen initiative is that there's not only a focus on precision health, but health delivery, which I think is a step further than most places that I know of that are focusing on precision health have gone. And I think that that's an area of potential commonality as well for implementation science and its focus on the delivery system as well as on specific practices. So I'm going to talk just very quickly about focusing on tailoring, because that's actually what a lot of my work is. I focus on designing and creating implementation interventions that are not completely de novo designed, but they come from some spaces where you're putting many different things together that don't normally go together. So that's the kind of design work I do. And this is just an example of work that we've been doing in the VA for a few years now. And we use feedback reports, an audit with feedback intervention, in long-term care settings in the VA. And I've given you an example of what one of these feedback reports looks like on the left-hand side of the slide, where we were basically looking, the thing that we were focused on implementing was goals of care conversations and what was called the Life Sustaining Treatment Decision Initiative, which is a national initiative across the whole VA, led by the National Center for Ethics in Healthcare in the VA. And what we were doing was giving long-term care settings, in this case, VA nursing homes or community living centers, giving them some information about, of the people who come into your nursing home unit in the last month, how many of them have had a goals of care conversation? How many of them do we have documentation for? And I should say very quickly that a big piece of this initiative is not just holding a conversation with people, but documenting in an explicit template that's part of the electronic record in the VA, that provides persistent orders and allows clinicians to know where they have to go to find out what people's treatment decisions and values and preferences for care are. So we were simply giving them a feedback report saying, if you had 7 people come in the last month, how many of those 7 had a goals of care conversation within the first 2 weeks of their admission? And as you can see from the bottom, it's variable by month as to how many people are coming in and then what proportion actually had a documented conversation. The dark blue means they had a conversation. The light green means they did not. So we did this intervention and gave these feedback reports to site champions at each of the community living centers in the VA that we were in our intervention set over about a 2-year period every month. In the middle of that, we did a survey across the same sites and asked a lot of questions about, what are the resources in the context of your site? We used an instrument called the ORCA, which was developed in Seattle when I was there working in the VA, and that addresses contextual and resource factors within VA, one of which is your perceptions of senior leadership. And these are the questions that focus on senior leadership. So just to orient you, each of these little boxes is a separate question. I'm not actually going to focus on the questions so much as just to show you kind of how these data work. So each box is a separate question, and each bar is a separate facility. And so in this case, we had 4 facilities. This was actually during our pilot phase of the work we were doing. And of those 4 facilities, all of the things that are above the 0 line are actually the strongly disagree statements. So these are Likert scale survey questions that ask people on a scale of 1 to 7, do you agree or disagree with this statement? What I want to point to is that these are 4 different questions about how senior leadership works in your facility for new innovations, new programs, and new things. And just that you can look across these 4 sites for each question and see what proportion of agreement or disagreement. So the agreement is down here in the blue bars. I'll just note that these gray bars, which you may not be able to see very well across the Zoom screens, those are actually the people who said, I don't know. And that's a problem with survey research that, especially in this kind of context, people don't always know the answer or they don't want to say. But we focused on the disagreement side of the scale. And what you see here is that there's actually quite a marked difference across these 4 questions about senior leadership. Do they give you resources? Do they reward you for innovation? Do you trust them to do what they should be doing with this innovation? And you can see that there's really marked disagreement. And there's actually a sort of a profile of each of these facilities that comes through this set of questions. And based on that, we actually added very brief tips to our feedback reports, that just little lines that said, you can perhaps try to change the way that you interact with your leadership. And in some instances, doing something called managing up, managing the leaders who are above you that you report to, as well as managing down and managing the staff who report to you. But we were focusing on the managing up component in terms of getting things from leadership that people felt that they needed. So that's an example of tailoring how to use data In this case, from surveys. Sometimes it's from interviews, and sometimes it's data that we can get that exists already about the setting or the context or the people, to tailor the feedback report in this case and to make it more effective, make it more meaningful to the people who got it. This is, I think, an interesting piece because, as I said, this is a commonality. This is an area where I think precision health and implementation science sort of do things in the same way. So on the implementation science side of the screen over here, I'm just pointing out that these surveys, if you look at these two different sets of questions, the top one is a question about, do you get the resources you need? And as you can imagine, lots of people say, no, we don't, because that's common in healthcare and then particularly in long-term care. And down here is actually a set of questions about how do you feel about your peers, the staff that you work with? How do they respond to change or to this particular innovation? And you can see here, there's much less disagreement. In general, people feel very supported by their peers, and in general, and this is a consistent finding we find across many different innovations, that your peers feel supportive and like you're doing this work together. When you go to senior leadership, perceptions change. It's not a uniform change. People, it's variable by context and by setting. I'm just over here, I just pulled, an image about SNPs, the single nucleotide polymorphism tools that are used in genetics. Just to say, this is similar. You're looking at, specifics about individuals. And in this case, eye color and hair color are not things that, matter very much in health outcomes. But there are a lot of SNPs that are about specific genes and patterns in the genetic profile that matter for health outcomes. And it's that same kind of tailoring that underlies the notions of a lot of precision health work, whether the focus is on genetics or on other aspects of tailoring. So I'm going to talk just very briefly about sort of our current state of implementation science. And this is just a very quick overview that I developed some time ago just as a tool to use with people to talk about what we do in implementation science. So it's a little bit of a roadmap that actually starts down here in the bottom left corner and follows the arrows through to the bottom right-hand corner. And what we focus on first is really what's the gap? What is the problem that we're trying to address? Because the whole focus of implementation, as I said in the definition that I gave you, that's my definition, focuses on changing behavior. If people are doing what they need to do already, if there's no need for behavior change, then there is no gap. And I don't need to be involved in that work as an implementation researcher. But articulating the gap is the first step and requires, as noted down here, the involvement of a lot of people and a lot of input. This is the sort of first step where real, true interdisciplinary thinking and work needs to come in. We then use a whole set of process models. There are well over 3 or 4 dozen process models in the implementation research literature at this point. This is just a small picture of one that I've used. And the idea of the process model is to help guide us, because one of the things that happens in implementation is that you get pulled off center frequently by all kinds of things. And so you have to stay very focused on getting the steps completed of the work that you're doing. One of those important steps is the assessment of the context and understanding what are the things that are going to make this easier or harder behavior change work to do. And there's a whole lot of theoretical and empirical work that underlies this very small little sketchy diagram that I have here, which is one of the determinants frameworks. It's the most recent consolidated framework, which means that this came out of a systematic review of the literature, and it outlines domains of areas to address, and then specific constructs within those areas. Then a lot of work has been done in implementation research around strategies and behavior change techniques. since that's the core business of what we do. This is one diagram that shows a clustering of ways to cluster the strategies that are out there. And then finally, there's a whole set of frameworks and outcome statements about what you need to measure, how you could do the measurement, and the importance of evaluating what you're doing. All of this is in the context of the real world. That's one of the things I think is sometimes different from precision health, depending again on the definition and how it's being done. But the work we do is always in real world context. It is within the delivery systems of care, as well as community agencies and community-based services, because this is about getting the behavior change that actually puts into practice the new innovations and ideas. So there are some differences, and I think that this is not something that I think needs to be belabored, but I think it's worth discussing briefly. A big piece of that is a question of what is the evidence? The work I've done, which has ranged from cardiovascular care in both inpatient and outpatient settings, as well as I've done work that's focused on hypertension, to some extent diabetes, lots of chronic diseases. What I look for first when a gap is established and we understand that there's a need for some kind of behavior change, that what's being delivered is suboptimal. The next step is, so what is optimal? What is better care? And the focus in implementation research, since it's the inception of the term implementation science, which is about 15 years ago, has really been on implementing evidence-based practices. And this is where I think it becomes a little complex to talk about precision health and implementation science in the same frame, because a lot of what's happening in precision health is the development of innovation. And the innovations may or may not have much evidence base. The thing I would say is that evidence is a multifaceted trait or construct. It's not a single thing. It's not just the results of multiple randomized controlled trials with a meta-analysis or multiple meta-analyses that pull together the data. The field I'm working in right now in critical care, there have been a lot of randomized trials. There's a lot of interest in understanding the evidence. The evidence is changing all the time. The last year's experience with COVID has actually changed our evidence base to some extent. And so being strictly bound by there is only one way to determine evidence of effectiveness or what's optimal is not useful. So this is an area where I think precision health is out on the frontier of development and innovation. Implementation science is more in the mainstream of saying, what do we know works and how can we get that into practice? I think that there is space in between that can be put together and we could work together effectively as long as we understand what we're talking about in terms of evidence. And then the other piece that really struck me as I was thinking about these two emerging fields and sort of where they center is that individualism and the precision about getting to the individual in precision health is a really key component of precision health, and it makes sense. So it's to drill down and get the person, the individual person with their specific, who they are, what their history is, what their genetic component is, their environmental component, and target treatment to them so that it will be maximally effective. We really don't do that in implementation research. That's a sort of a subfield, where you're focusing perhaps social influence on an individual. Social marketing is often very targeted to individuals, even though it's a broad social message that's being targeted. The work I do is more about trying, and I think it fits better with the population focus of precision health than the individual focus, trying to understand what are the populations of context, of the organizational constraints that people are working under that have generalizable regular principles and actually would allow you to generalize across different settings and different contexts. So I just note that because I think that this is an area for discussion and for thinking through some of these things rather than making the assumption that because there are a lot of areas of commonality, these things will work together all the time. They may or may not. So moving to the working together part of this. As I think about, of course, I'm coming from the implementation side, science side of things. It strikes me that precision health products, the innovations being developed out of precision health, need implementation. And so that can come across as you need us, maybe more than we need you, but maybe not. Because if you think about the build a mousetrap, build a better mousetrap, people will buy it. They don't. And that's one of the things that is something of a conundrum. It's very frustrating to the developers, to the people who have put time, energy, often their life and their soul in developing innovative, valuable, and valued products that despite their value, the value isn't seen and people don't come, and there isn't automatic adoption. Some things do get adopted very quickly. I would argue that there actually are forces underlying that adoption that are sort of running through on a societal level often. And sometimes that comes from the weight of a big trial or big headlines about something. But the reality is that for most of the mousetraps that we build, people don't flock to buy it. And many of the mousetraps we build, work again for some populations better than others. I really do think that using the tools that we develop through implementation research can help with that, can help people find, in the case of commercialization, the markets. It's interesting to me that what people in the commercialization part of academic research in intensive universities and academic health centers do is often very similar to what we do in implementation research. And I think that we can find lots of commonality there. But I would also say that the science of implementation needs innovation. And I think that it could be very, very generative to translate the notion of precision into implementation. And as Dr. Barron said in his introduction, there's this emerging concept of precision implementation, which actually really is what I described earlier in terms of tailoring. And it focuses on trying to understand these regularities and apply information from the context in which you're working to actually make the innovation or the implementation go better and overcome some of the barriers that exist. But at this point, our tools for doing that are quite blunt, and frankly, they're old. In the determinants frameworks that I talked about very, very briefly, barriers and facilitators are catalogs of these things. The terms around information implementation, or I'm sorry, information systems and electronic health records are minimal to non-existent. And yet that's where people are focusing their energy on doing implementation. And in fact, in critical care, that's where a proposal that a colleague in New York City and I have under review right now focuses on not only using data from digitally extracted data from the electronic health record, but also digitally transforming the data into the tools that we will use for implementation. Feedback reports clearly lend themselves to this kind of work, but there are other tools that have yet to be developed. And some of these are things that we proposed in the work that we submitted, but we found ourselves with very little in the literature to draw from the implementation science literature. So there's a huge need for development and innovation in the space of strategies and approaches to be used in implementation. And we have to build an evidence base around those things. So I want to just briefly talk about the diffusion of innovation. And this is one of the early precursors to implementation science. This was work done by Everett Rogers at Iowa State University, starting I think he started working in the 1930s. focused on agricultural extension. He actually never worked in health, or I shouldn't say never. He had very brief forays into healthcare, although many of the people who studied with him went into healthcare, doing implementation work. But he himself focused on agriculture and using agricultural extension agents. And this is one of the things I just want to note. As a land-grant university, the University of Missouri has an agricultural extension network. And I've learned, in the last day or two that that health has become part of that extension network now, which I think is incredibly exciting. But the idea that he came up with through observation, mostly interactions, observations, and then towards the end of his career, some experimentation, was that people don't simply take up new ideas. And there is regularity to this, that there is a very small proportion of any group of people, any population of people, in his case, farmers, who are willing to not only take up new ideas, but actually innovate, do new things themselves. They are the experimenters. There's the ones who sort of look at things and say, I could do this differently, let me try this. That's about 2% of the population. In a couple million people, that's still a lot of people, but over, a state or a county, probably not so many. Then there's a group of people called early adopters in his language, and that's about 14% of the population. So between the two of them, you're at about 15 to 16% of the population. And those are the folks who are willing to take on new ideas. They don't do the experimentation themselves, but they'll take it up and they'll try it and help to figure out, in this case, does this work well or not? They are critical. That small group is critical to actually getting to the early majority group, which is where you start to get into the bell part of the bell-shaped curve that you see in the little picture. That's about 34%. So by the time you're hitting that early majority and starting to get to the 50% mark, you probably have most of the people who will adopt something that's different and change behavior. Actually, do all the work that's required to do things differently. The late majority, it could be years. And with the laggards, they may never change their behavior. They may or may not, chances are not. This is where sometimes for full behavior change and complete routinization of new practices, sometimes is generational, that people will have to retire before you get to full implementation. And you may never get to full implementation. But getting to that first, tipping point, as Malcolm Gladwell wrote about in his very popular book, really takes first the innovation, which is where I see the precision health next gen initiatives sort of sitting. Then the initial work with early adopters, finding them, convincing them, getting them to adopt, and then to help move it on to the early majority is most of the work we do in implementation research. And I think it's the work that needs to be done with precision health, with NextGen, and with all of the initiatives that constitute the transformation of not only the healthcare practices that we engage in, but also the delivery systems that serve people and actually deliver the care to populations and to individual patients. So that's most of what I had. I do think that there are some emerging frontiers that are important for implementation science. One of the things that we're doing, and this is being fostered very directly within the VA, which is one of the places I work, is to work directly with clinical trialists. This is an area where we sort of stayed away from. We've been focusing, if you're familiar with the T1 through T4 translational pipeline language, we focus more on T3 and T4, which is the routinization into regular patient care and then population health side of implementation. But there's work that can be done, and there's actually probably significant value in getting the trialists, the people who are often the innovators, and they're certainly the experimentalists, thinking early on about what it will take to actually get this new thing that they're testing assuming that it's effective, or it's effective at least for populations, getting that implemented into practice. So we're working on awareness and training trialists and embedding that thinking and planning into trial design and conduct. So I'm actually working with one of the cooperative studies trials in the VA that's been approved for trial across 40 sites in the VA. We're in year one of a 10-year trial. And the idea is to build, by the time we get to years 8, 9, and 10, we will have a plan for implementation of the findings that will allow that to keep moving, rather than the sort of pause point that usually happens with, now we're going to get our publications done. And after the publications, then we'll see what we do next. And for most trialists, the next thing is another trial, the next trial, a different trial. It's not implementation. And then I just want to say that there is a group of study designs and trial designs within implementation. It's been developed by implementation researchers that actually works on trying to have dual lanes and both growing the evidence base as well as understand how to do implementation at the same time, rather than saying we have to wait for the evidence before we can implement. That may be an important thing for precision health, because chances are good that many of the innovations may have small evidence bases that need to be developed further, in addition to thinking about how to implement. So summing up, I think there are some really important and key areas of commonality between these two really emerging and rapidly evolving areas. There are some differences in both approach and perspective. I think the importance of evidence is a key difference that we need to think through, and the meaning of tailoring. How do we tailor? What do we think tailoring means is probably something that will be important to work through. And then I think that we have to have clear paths for working together, thinking about how to find each other and then collaborate to make the work that both of us are doing more effective and more relevant in the rapidly emerging context of new innovations in healthcare.
Thanks, Dr. Sales. That was tremendous. Mary Hindle, our senior educational coordinator, is going to ask some of the questions that came in on Q&A, but let me start. Question and observation. You sort of alluded to it, and I asked you this question during our one-on-one before. How much data from an implementation science comes from the electronic medical record? I guess some do, some don't. You sort of alluded to that when you were talking about a study that you were just submitting. Can you expand on that a little bit?
Yeah, that's a great question. And the answer from me is pretty close to 100%. The work I do uses electronic health data pretty exclusively. And that's partly because I focus on feedback interventions. However, I have a lot of colleagues internationally who work in systems where there is no electronic record yet. And they're doing feedback interventions. So they actually have to collect the data that they're going to use for feedback, which I think is very inefficient. I don't just think that, it is very inefficient. And it makes it much more expensive and much harder to do that kind of intervention. So my own feeling is that, first of all, and there is evidence for this, not just a personal feeling, feedback is a core modality in implementation. If people don't know what their performance is, it's very hard to get them to think that they have to change their behavior in any way. So informing them is essential. And those data, from my perspective, need to come from sources that exist, rather than having to generate that information through data collection.
But I always get in this argument with my information scientists, because they always tell me there's gold in the EMR. And I always say, yeah, well, some of it's, nickel, and we need to put more formatted fields in the EMR where we can get data out that means something to the doctors and ultimately to the patients. And so it's encouraging to me that 100% of what your data you're getting is out of the existing EMR, even without what I think we have a long way to go till we get more structured data in the EMR.
Right. And I think that the structured data, yes, I think we're developing tools. I have colleagues who do natural language processing, and The problem is those are boutique right now. We really need them to be mainstream. We
Right.
need those to be established pipelines. But I think the other piece is there's a lot of data that don't enter the EMR, and that's the data about the
Right.
context. You can infer some of it sometimes, but that's where we have to go out and do data collection.
I know we have 5 or 6 questions here, but I just can't resist this observation. So I gave the opening Next Gen Physician Health talk, and I gave some examples in my field of neuromuscular disease where we now know the gene for some of these horrible pediatric diseases like spinal muscular atrophy. And because of that, we have therapies that can basically stop the disease. So essentially, we have 100% compliance in physicians getting
Right.
gene testing on these floppy babies now,
Right.
because we have a therapy that works. So that's implementation science in action without,
Yeah.
so
Right.
it sounds like the challenge is when the evidence is not as definitive, is when you have to build a case for
Right.
implementation science.
Right. And also where people haven't been waiting for years to get to this point. And I
Right.
think, so I would say, in fact, some ways, that sort of intuitive implementation thinking has been sitting there for a long time. And the folks who do that kind of rare disease care
Yeah.
are waiting. They're primed. They're ready
Yeah.
to go.
Mm.
But rare diseases are rare. And
Yeah,
so,
I get it. I
Yeah.
always think in that lens. Okay, Mary Hindle, go ahead and read off some of the questions for Professor Sales.
Thank you. One of the challenges of genetic screens is that many sequences on the chips are actually incorrect. Thus, SNPs are misidentified. This is because the technology has moved faster than the science. Are there corollaries in implementation science?
yes, yes, I would say there are plenty. They're not as easy to identify because one of the big issues in implementation science is our measurements aren't very precise. And so we sometimes don't even know when we're not hitting the target very well. But there's no question but that we have, gone after things like in context that we've tried to work with, tried to develop tools to work with, and approaches that are more generalizable, and we failed. And I think that this is partly why I think some kind of thinking about precision and certainly its measurement and how we can become more precise is really essential in this discipline as well.
Thank you. When you use electronic medical records, how much of the nursing notes or inputs are used for your work to improve health outcomes?
I have to say probably almost none. Nursing notes are actually notoriously free text. Actually, in the VA, we tried to put together a nursing assessment tool that would cover nursing. It was 90 screens with probably close to 1,000 clicks, and it was completely unimplementable.
Wow.
So it was abandoned. So nursing notes are actually seldom used. One of my colleagues at Utah has done some work on this, and she finds that they're not used. And one of the reasons they're not used is because a lot of people feel that they don't give much information. They're bland and generic. They don't describe what's really happening. And if they're not used, they don't get better. And this is one of those things about data from whatever source, that if you don't use the data, you can't improve it. And I think that's one of the problems with nursing notes. It's an interesting question, and I think an area for more research and thinking.
And if I could jump in, this is coming from a nurse, Dr.
Yes.
Sales, the nurse.
Yeah.
Will you educate us on some of the measures used to study implementation?
Yeah. I mean, part of what's complex is that the core measure, the thing that you most want to know is, did you change the behavior that you wanted to change? And that is specific to the problem. So for example, when we were doing implementation around adoption of statins for lipid management in ischemic heart disease, what we wanted to see was increased use of statins and improvements in, hypercholesterolemia, and in particularly low density lipoproteins. And the thing that is problematic there is that that's a measure that doesn't translate to diabetes. It doesn't translate to hypertension. It's very specific to that problem. So we do have a set of measures that are being called implementation outcomes that are more generic and more useful across different kinds of problems. And these are things like acceptability, feasibility, satisfaction. And I use those. I think we all do, but they're not terribly useful in terms of understanding, did this really work? And for that, you really have to develop measurement that's quite specific to, sometimes it's increased prescribing, like prescribing of statins, but ultimately you also want to know, did this actually matter in terms of health outcomes?
Great. You mentioned a 10-year study. Could you talk about how the process and the evidence might change over time when you have such a long process for trials and implementation? How do you keep the products relevant for evolving populations?
Well, this is a big problem in trials because trials take a long time, and it's the accrual of patients, as well as the length of time to see the effect of a drug that may take, 2 or 3 years in a chronic disease to manifest an effect. But I'll tell you honestly, I'm frankly terrified. I've barely lived anywhere for 10 years, much less studied something for 10 years. So this is going to be an interesting journey into really thinking about, how will it change? I mean, clearly the evidence base, even as they have put this trial together, which is a repurposing of an old drug for renal disease, there's a new entrant on the market that potentially might be more effective, and not only for renal disease, it may also affect cardiovascular disease and other things at the same time. That's a big challenge. It's a big threat to getting this trial done because there's a strong probability that many of the patients who would be started on the study drug will end up on this new drug instead, because that's the decision that they and their provider make. So I have to say I don't know the answer to that. I think getting into this kind of early phase trial work and development will, I think, be challenging, but it'll also allow us to innovate in terms of the implementation work to understand what we're doing and how we're doing it best.
Wow, thank you. Your publishing record in PubMed shows you work with many different types of medical investigators. How do you choose what types of implementation projects you want to work on? And do you have a role in team building for these projects?
I sort of asked Dr. Sales
Yeah.
that when we hit our one-on-one.
Yeah, and there isn't, the answer is, people come to me and a lot of times it's sort of what pans out. And that reflects the degree of commitment that the other person has or the other group has to implementation, which is a long process and it's a complex one and it adds cost to any study. So, there are just realities around that. But it's also about, I think very much the team building piece. How are we working together? The work I'm doing in critical care really started with meeting somebody over breakfast at a conference about 8 years ago. And, we started saying we'd like to work together. It took us a couple of years to get our first, dance card opening for the both of us and starting to actually put proposals together. And now we're at the point where we've done one project together and moving on to a largish scale trial. And I think that the reality is that that's how most implementation researchers work. Some people are very focused on a specific domain, like substance abuse or something like that. I'm a generalist, and I find it interesting to work with lots of different people across different domains.
Thank you. Do you know if implementation science has been applied to reduce physician burnout?
Not as far as I'm aware. And I think one of the questions is, what's the evidence there? What is effective in reducing physician burnout? In the world of nursing, burnout has been studied for years, and it's been present for years, to the extent that, the statistics apparently are still what they've been for 20 or 30 years now, which is about 30% of all new nurses leave nursing practice in their first year. And that's not true of physicians. They hang in there a whole lot longer. But I think the effects of burnout on physicians are profound, as they are with nurses who hang in there. And the problem is, I don't know that we have great, effective, evidence-based solutions for that. There are some, and there are things that people have tried, but that's an area where I think the idea of a hybrid study, where you're developing the evidence base as well as the implementation approaches, because I think implementing things for physicians, which is different from working with physicians to change their practice, is kind of a different challenge. And I think it's worth pursuing. But as far as I know, no, that's not being done.
Thank you. Could you talk a little about funding streams for precision health
Mm.
versus implementation science? Do you see them as separate or overlapping funding streams?
Well, I think they could overlap. I mean, one thing I think I can say, truthfully, for the last decade, the funding stream for implementation science has been good. And because of that, we've had a lot of people, enter the field. We routinely get people who are interested, generally young investigators who've had research training in, a related field or clinical training, and want to learn about implementation research. So the funding there is good. My sense is that that's also true for funding of other kinds of precision health initiatives. I think that is probably still on the sort of emerging stream rather than necessarily there. But I have to be honest to say I don't know that world as well.
Okay, and our last question for you here on the Q&A is following up on the question about utilization of nursing documentation in the EHR. Are you familiar with the Rothman Index, which utilizes nursing documentation to monitor for patient deterioration?
Yes, I am. We actually looked at incorporating the Rothman Index into using it at Michigan. I mean, what it is it takes the data that's already in the EMR, analyzes it, manipulates it, and then comes up with scores. And there are a lot of deterioration indices out there that work better or worse. My feeling about the Rothman Index, which has been used extensively by a colleague of mine who's in the School of Nursing at the University of Michigan as an outcome, both input and outcome, is that I'm not sure what its precision is. And this has been a problem in nursing for a long time. We have sought after the holy grail of acuity measurement for decades now. And part of the problem is we're trying to measure across very heterogeneous patient groups, and we're trying to include everything in acuity. So, at this point, I would say I think the Rothman Index is interesting, and I know it's being used. I've not worked with it myself. I think it's something to think about more. And if it's available, I think it's definitely worth looking into.
Thank you so much, Dr. Sales. I'll turn it over to Dr. Barron.
All right. Well, Dr. Sales, once again, thanks so much for this really stimulating Discovery Grand Rounds lecture series. And we're just so pleased that not only were we able to give this lecture, but also come to Columbia, meet with many of us in person. So we're all enjoying that for the rest of the day and tomorrow. So thank you all for joining in to this series. We had many people listening to Dr. Sales talk, and it's also recorded, so you can tell your colleagues that if they missed it, they can still watch it later. So once again, Dr. Sales, thank you very much.
Thank you.